Thank you, Kelly. I wanted to introduce our another panelist, Gary Wendt. He's Enterprise Director of Medical Imaging and Vice Chair of Informatics at the University of Wisconsin. He's currently the Associate Professor of Radiology, and he focuses in a lot of informatics, PACS, and enterprise imaging, and he also holds an MBA. So Gary and I share we're both conveners in the Medicare imaging demonstration. We just want to give you a little update on that. So the CMS imaging demonstration is really trying to assess whether the government or CMS is going to go the route of including decision support systems as a requirement for exams that are performed on Medicare patients, and to sort of circumvent, because they're considering going to an RBM. And so are they going to go the RBM route, or are they going to validate these types of clinical decision support systems to be put into electronic health records? And I'll let Gary maybe just update on his enterprise and how that's going.
Yeah, we're now implemented at 4 organizations comprising over 2,000 physicians, everything from a tertiary care hospital to the University of Wisconsin clinics, all the way to a primary care hospital and a large HMO. So we're fully in production and have been rolling with that now, and we're using what is to become the ACR Select product. So I think it's been a good experience overall. I think one of the biggest things we've learned is that it really helps to have top-down buy-in when you're doing this. It really shouldn't be driven by radiologists. You really have to have buy-in from the upper level management to get all the physicians on board with this. Some of the other key lessons we've learned is that the integration with your EMR is really critical for ordering physicians. We'd like to be able to change it a little. We're working with Epic. We're working with the ACR Select product to see if we can't tweak the ordering process a little so that it's easier for physicians to be able to select the appropriate test that's recommended rather than having to cancel what they were going to order and back all the way out and reorder again. So overall it's going very well. It was a challenge. It's something that I think is going to be coming down the pike for a lot of organizations. Outside of just the CMS project, we've had several large insurers in the region grant us waivers of either prior auth or RBM in exchange for having a DSS in place. Currently, none of them has actually made us put a hard stop in on any of the scoring. So all we actually have to do is provide them with reporting data, and provide feedback to our referring physicians. And I think the hope is that the feedback to referring physicians will sort of induce that competitive nature, not wanting to be on the very bottom of the pool. So they're hoping that that'll actually be enough to drive appropriate reductions, as opposed to having to go to the point of doing hard stops and blocking ordering and having to call for approvals. So it's been going well.
Any questions from the audience on how to implement these systems or challenges? Yes.
So one of the interesting parts of Kelly's presentation is that this curve over 6 years. I don't know how long you have the system. Do you have any statistics that can impact on utilization? Can you repeat my question, because most of them.
We haven't had the system live. We actually did a baseline where we were actually running for 6 months without any feedback. We basically collected scores, but the providers didn't see anything at all. And then we've recently turned it on, so we're not far enough out yet that you could actually get a statistically valid trend. And I think that's the whole point in the mid demonstration, is that that's their reasoning in running it for 2 years, is that you want to have a long enough period of time that you actually can get something that's statistically valid.
Okay.
Right, so we're about a year in, so 6 months of it is baseline here at Henry Ford, and then we're 6 months into intervention phase, where we're showing decision support scores. All the data will be done after the 2 years by the RAND Corporation for the MID project. So that hasn't been resolved yet. The other interesting thing is, so each convener site has a different way of approaching it. Some places where they have all physicians ordering these exams and seeing the scores. Other places, like in outpatient centers, a lot of the CSRs, MAs, nurses are the ones ordering these exams. So there's a lot of discrepancy in the intake of these orders. And that's going to be a big question I think CMS is going to raise, is at what point do physicians have to be exposed to the orders on their patients?
Well, and I think that's one of the big points of like the CMS project itself, is they actually do require that the pathway for order entry is well enough defined that you have to be able to ensure that the providers know about their scoring in one manner or another. So I think, you know, if you're going to implement it, I think that's an important point, is you really need to look at your ordering process and make sure that even if you are doing order entry, you know, somewhere down the road and the referring physician isn't doing it directly, make sure there's some way to provide relatively immediate feedback. You know, if you go through doing the DSS and you implement it and the referring physicians don't hear about how they're doing for 6 months, you know, it's going to be really of very little use to them, and it's not going to change their behavior. So,
some of the rendering providers, the radiology groups that are independent, what they did is they actually provided an icon on the computers inside of the ordering clinics, so that though they were having the system available through their organization, it was on the immediately available and on the computer right at the ordering site. So because I think that I agree, and we've experienced that immediate feedback. I mean, it's really good for the providers, but it's even better for the patients.
Yes.
I just got a quick question. How much of the information in the process became transparent to the end user radiologist? You know, Medicare regulations have for years said that the referring physician has to provide adequate clinical information to document medical necessity. However, we're all subject to patient orders coming through that says pre-op or admission or whatever. So how much of that is coming back to the radiologist?
well, we feed everything back. All of the indication, anything that's provided to the DSS system, it gets fed back through, and it's actually immediately available to us, both in the medical records as well as directly within our PACS environment. So we actually see everything.
Yeah, and we too, in the those that are using it through an EMR, it's just transmitted, so that's really nice. We actually, in those that were using web-based, we actually worked a way to print, because some of these are still living in a paper world, they could actually print right from that ordering the decision support system, and the patient could actually carry it with them, or they could send it, fax it. You know, so what we really did is we created workflows that took advantage of the workflow that they already had, and then just added the decision support onto it and worked it through their normal workflows.
And at our institution, we force an ICD-9, so at the very least, we have that. The only place they can freeform is in the history component, but if they want to activate the decision support system, they have to choose a scenario. And if you're adding pre-auth to it, if you don't have, let's say, an adequate score, for instance, then you're sort of forced to give that clinical history, at least a clinical history, even though it may not be correct. Have any of you noticed any gaming of the system, at least ways around trying to get a score, or at least trying to look like they're above the mean?
We actually track that with the Radport system. You can actually track that. You can see even how a person would go in, an ordering provider could go in, come back out, change the indications, go back in, you know, go back and forth. You can track that. That's really valuable. We actually haven't had a lot of problems with that, but we told them right up front that we could do that, so they knew we could watch it. I don't know if that mattered. I'm suspecting it did. But we told them we knew we could watch that. Now, inside of each organization, they could use that data also. And so we've allowed them to use it, and they've used it for both education and remedial training.
You know, and at least in our environment, everything is tied, you know, the PACS is tied to the medical record, so you're actually looking at both at the same time. And it, you know, I think it'd become pretty apparent to the radiologist if you started reading exams where the DSS score was discordant with the medical record. And I really don't think that physicians are going to try to do that simply because it would be really falsely documenting. I mean, the bottom line is they know that that decision support score goes back to the medical record. It's part of the patient's permanent medical record. And putting in something that's incorrect there is no different than falsely documenting problems directly in the medical record. It's the same thing, so.
We did a chart review, an actual go into the chart on 300 charts, and just looked at before they had decision support and after they had decision support, and did the chart support the actions that were taken, and were the indications actually what the indications clearly were in their record. And we found between a 10 and 26 and 39, depending on the type of exam it was, but we found statistically significant increases in appropriateness, clear documentation, and appropriate actions taken from before decision support and after decision support.
Last questions back there, maybe those 2 or 3.
I was just going to say, Callie, during your presentation, you made the comment how important it is to have a common set of appropriateness criteria. So I was hoping to hear from Dr. Wendt and Dr. Halaby. At your institutions, would you say overall that the ordering clinician groups would say they kind of support a national standard, so to say, let's call it that, or do you get grumblings that there should be, you know, some serious localization of the rules?
We haven't seen it. I mean, there was a desire for the specialist to actually see what was going to be there ahead of time. They wanted to review it, but we didn't get any serious kickback that, you know, oh, the indications, you know, you're giving are just unacceptable. I mean, there's still always the option to add, you know, local indications, but if they don't match up with the ACR appropriateness criteria, they just won't get a score. I mean, you're always going to have a certain percentage of your exams that are just not scorable.
And in our institution, the decision support, because of the demonstration project, they're very anemic. It's not a very broad-based. People are used to Google searches, right? They expect a Google-type search to be able to find their clinical indication and a guideline to support that. And I think that's one of our biggest issues right now is I can't find, you know, X, Y, or Z. And then the specialist will say, didn't you just read the article in our journal last month regarding that indication for MRI for post-prostate cancer patients? So we're dealing with that. I think people do understand, though, this is sort of base level. We're trying to educate them and let them know that this is just first phase. It will evolve over time. And hopefully the feedback to the ACR and any of the other vendors will provide a better, richer source of information. We'll just take one more question.
Can you speak a little bit to how the scheduling process interacts with the DSS process?
So at our institution, anything CT, MR, or nuclear medicine goes to a protocoling system, and each study is protocoled by a radiologist with the score, with the decision support information, and then after it's, you know, massaged by the technologists and the CSRs, it's scheduled after that point. All the labs have to be in. It doesn't get to the protocoling system until it has certain information, and I hope that answers your question. I don't know what you do at your institution.
Yeah, ours is the same way. It's scheduled after.
All right.
The order is actually placed under the radiologist's name or the referring physician's name?
All the orders are placed under the referring physician's name. And if it's done by a proxy for that physician, they have to attest that the physician is aware of the decision support score. All right, I wanted to thank, again, our panelists. Actually, I actually had a text message question here. In terms of the ICSI model, can you speak to the use in the inpatient and emergency areas?
They're using it in the inpatient and emergency areas, not broadly. It was developed to be used in the outpatient, but the criteria are applicable in all settings, so it is being used, and they're really liking it. We actually, I do have to say, when the Nuance made their announcement, we actually went back to all the providers, the 9,000, and we said, you have an out. You have a way you can stop this now, because if they're going to go away, you can stop this. No one wanted to stop it. Not one organization stopped it. So clearly, it is a better solution to have decision support available than it is to have an RBM or other solution.
Thank you very much.